Assalamu alaikum. Very good morning. Welcome to you all in today's discussion. Today's topic is very common acute interstitial nephritis. Let's start with a classic exam oriented practical question. A 55 years old woman presents with fever, scanty micturition, and a history of intake for NSAID for low back pain. Now, what are the differential diagnoses? If you think acute interstitial nephritis immediately, you are already in the right track. So, what is the definition of acute interstitial nephritis? AIN is an immunomediated inflammation of renal interstitium and tubules caused by drugs, infection, and immunodisease. So, AIN is primarily a tubulointerstitial disease. Tubulointerstitial disease. It not involve glomerulus. Here, glomerulus is normal. If glomerulus is affected, then it is called glomerulonephritis. But in case of AIN, the disease is mainly in renal interstitium and tubules. Etiology. Causes of etiology can be divided into three broad groups. Number one, therapeutic agent, that is drug induced. The most common drugs are antibiotics, NSAIDs, and proton pump inhibitor. In case of antibiotics, beta-lactam groups, that is penicillin, cephalosporin, and quinolones are common. In case of diuretics, mostly thiazide and loop diuretics are the culprit drugs. Proton pump inhibitor is very much common for causing acute interstitial nephritis. Always remember, drug-induced AIN is the most common cause and it is about 70 to 90%. Next, causes of acute interstitial nephritis is infection related. It includes tuberculosis, various bacterial infection including leptospira, legionella, and viral infection, that is Epstein-Barr virus, cytomegalovirus, HIV virus. Leptospira infection is very much common in our day-to-day practice. Next, immunomediated disease. It includes sarcoidosis, Sjogren's syndrome, SLE, and Tinu syndrome, that is tubulointerstitial nephritis with uveitis. An acute obstructive disorder, that is myeloma kidney, acute phosphate nephropathy, and acute urate nephropathy. So, regarding etiology, most common is drugs, next autoimmune, and last is infection and obstructive disorder. Now I will discuss about clinical presentation of AIN. Classically, we know a triad, that is fever, rash, and eosinophilia. The classic triad is less than 10% of patient. It is very rare. Patient actually presents with incidental rise of serum creatinine, symptoms of AKI, and it is usually non-oligouric AKI, sterile pyuria, and mild proteinuria. Always remember, hypertension and edema is uncommon in AIN. Important NSAID clue. In case of NSAID-induced AIN, patient typically lacks of fever, rash, and eosinophilia. অর্থাৎ NSAID দিয়ে যদি হয় তাহলে এইগুলো থাকে না. Patient rather presents with AKI and significant proteinuria. 75% cases, patient may presents with nephrotic syndrome. In case of rifampicin clue, re-exposure to rifampicin after a drug-free interval can cause severe and rapid onset AIN. Investigations of acute interstitial nephritis. Urine analysis. There is mild proteinuria, usually less than 1 gram per day, sterile pyuria. Urine for eosinophil is found in Hansel strain and WBC cast may be present. If you found WBC cast without bacteria, always think about acute interstitial nephritis. Blood test. In case of blood test, we can found peripheral eosinophilia around 25 to 35% cases, raised ESR, raised serum creatinine and urea. Fractional excretion of sodium, that is FeNA, is more than 1%, that is consistent with acute interstitial nephritis and intrinsic AKI. Imaging. Ultrasonography, usually normal or slightly enlarged kidney. Chest X-ray to identify sarcoidosis or tuberculosis, and serum ACE level may be elevated in sarcoidosis. Autoimmunoprofile to diagnose the SLE or Sjogren syndrome, that is ANA, RO, anti-Rho, anti-La may be positive. Renal biopsy. Renal biopsy is the gold standard, especially if diagnosis is uncertain. What we found in light microscopy, that is infiltrate of monocyte and lymphocyte. Number 2, interstitial edema, and the hallmark feature is tubulitis. You should never forget about tubulitis. Eosinophils may be present. You may ask about tubulitis. What is tubulitis? Tubulitis is caused by whole inflammatory cell breaching the tubular basement membrane. অর্থাৎ আমাদের যে টিউবুলার বেসমেন্ট মেমব্রেন থাকে, এই টিউবুলার বেসমেন্ট মেমব্রেনকে যদি ছিঁড়ে ফেলে, ব্রিজ করে ফেলে ইনফ্ল্যামেটরি সেলের মাধ্যমে, তাহলে যে লেশনটা হয় সেটাকেও টিউবুলাইটিস বলা হয়। হোয়াট ইজ টিউবুলাইটিস? Tubulitis is the inflammation of tubule caused by breaching of tubular basement membrane. DIF, that is immunofluorescence and electron microscopy, typically negative. Usually negative. No immunodiffusion is found here. Exception in case of penicillin and cephalosporin induced acute interstitial nephritis, we can found IgG and C3 deposition and linear pattern. So in DIF, no deposition. But if the AIN is caused by penicillin or cephalosporin, that is beta-lactam antibiotic, then we can found IgG and C3 deposition. The pattern is linear. Management. Step 1. Stop the offending drug. Stop the offending drug. It is the most important step and never should be delayed. Step 2. Supportive care. That is fluid balance, avoid nephrotoxic and do dialysis if needed. Step 3. Corticosteroid. Steroids are beneficial, especially when renal function does not improve within first week. যদি রেনাল ফাংশন আমাদের সাপোর্টিভ কেয়ার এবং ড্রাগ বন্ধ করার পরেও 1 সপ্তাহ পর পেশেন্টের ইমপ্রুভ না হয়, তখন আমরা স্টেরয়েড শুরু করি। দ্য রিকমেন্ডেড রেজিমেন ইজ 1 milligram per kg per day, maximum 60 milligram. Begin tapering after 1 to 2 weeks later, and total duration is 4 to 6 weeks. 4 to 6 weeks. Here a study shows that short-course steroid therapy is effective as the prolonged থেরাপি, অর্থাৎ কম্পেয়ার করছে 3 উইকস স্টেরয়েড থেরাপির সাথে 8 উইকস স্টেরয়েড থেরাপি, দেখা গেছে দুইটাই সেম ইফেক্টিভ। In case of NSAID-induced acute interstitial nephritis, steroids do not significantly alter the association of nephrotic syndrome. If it is refractory, then MMF has a little role on acute interstitial nephritis. So, indication of steroid in acute interstitial nephritis. First is not improve after 1 week. Then some absolute indication, that is autoimmune disease association, Sjogren's syndrome, sarcoidosis, SLE, TINU, IG4 related disease, and idiopathic not improved. And relative indication is drug induced or rapidly progressing diffuse infiltrates, impending need for dialysis, and delayed recovery. What are the prognosis? Prognosis is generally good if diagnosed early. Good prognosis depends on early diagnosis, early steroid withdrawal, and steroid therapy. Poor prognosis is delayed diagnosis if interstitial fibrosis and NSAID-induced AIN. What are the differentials of AIN? Its differentials are include AKI with pyelonephritis, acute pyelonephritis, chronic interstitial nephritis, SLE, acute tubular necrosis, ATN, and myeloma kidney, that is cast nephropathy. If we found AKI with eosinophilia, what we should think? We should think about acute interstitial nephritis, EGPA, cholesterol emboli, malignancy, and IG4 related disease. So remember, AIN is very common but underdiagnosed, and it is reversible if caught early. So always suspect AIN in unexplained AKI with drug exposure. This is all for today. Thank you very much.